today's speaker. Ralph has more than 20 years of experience in healthcare finance, leadership, reimbursement, and operations. He began his healthcare career as a hospital CFO for a 49-bed hospital with a 116-bed nursing home. Ralph enjoys providing innovative solutions to the challenges in today's healthcare environment. He assists providers by developing solutions focusing on cost report reimbursement, charge master development, billing compliance, operations leadership, organizational structure, process flow, board education, licensure status, and electronic health record incentives. Ralph is a frequent presenter and lecturer on emerging healthcare topics at state and national conferences for the Healthcare Financial Management Association, American Institute of CPAs, National Rural Health Association, and state hospital associations. We are lucky enough to have him as today's presenter. Now I will turn it over to Ralph.
Good morning. Well, first of all, I want to thank everybody for joining us for the first of what's going to be 3 sessions on the road to value. And the sessions in between now and the next 2 sessions will go over the road to value financial strategies. Then we'll get into some positioning in the next 2 sessions, talking about what providers need to be looking at doing at this very important and very challenging time in the healthcare arena. So we'll just get moving along here. As we look at the road to value agenda today, we have about 7 things, I guess, here that we're going to hit. We're going to talk about the why. You know, why do they need to start looking at preparation now rather than waiting? We're going to talk about some indicators that they need to be monitoring and managing, and you know, why now? You know, why in the future will they be looking at these indicators? We'll talk about how to monitor the indicators, why they're important to be strong today. We'll talk a little bit about documenting value, and then we will wrap up on the back end with a key strategy overview. So why the need to prepare for the transition? When we look at what's been going on, and this is the stuff that's been in the news for, you know, many, many years now, the historical growth in healthcare spending is just at a rate, or has been at a rate, that's just not sustainable. And I'll show you this slide here in a few minutes that shows what's been going on as far as the percentage of GDP over time and why that's not sustainable. At the same time, we're starting to see new payment models. And some of these have been proposed. Some of them are starting to be even implemented. And those that are being implemented right now are probably most often in larger organizations. When I talk larger organizations, think the PPS hospitals, those that are under the normal acute care licensure, typically getting paid under a DRG or an APC reimbursement methodology for inpatient and for outpatient services. So we've got that going on in that arena. And at the same time, when we see what's happening to our patients, as well as us as individuals, and what's happening in the payer arena, they're demanding changes. Most of us, if we have not seen it in the last couple of years, are probably at the point of seeing it happen, where we're seeing our co-insurances and our deductibles, our out-of-pocket component, becoming a much larger portion of the pie as far as reimbursement goes, especially for first dollar coverage. You know, that first part of the year right now, the payer is the one that, or the patient is the one that is responsible for paying that bill. And now that they're responsible for paying it, they're doing a lot more shopping around. They're asking a lot more questions about pricing, about value. You know, what's it going to cost me? What am I going to get? That's a big change from when the insurance company was paying most of the bill, and you know, the cost and the value, it wasn't necessarily as big of a deal to the patient. So all of this is forcing people to have to start looking at a change in the way they operate and how they sell and how they demonstrate value to that crucial patient. What we have here is and I know the slide's pretty small here, but it shows the GDP as with healthcare as a percentage of it from 1970 up until 2013. And we can see during that time period, healthcare spending went from 7% to 17%. And as you can see along the way, it rarely leveled off until the last couple of years. And a lot of that leveling off is being attributed to the fact that now all of a sudden patients are having to have higher out-of-pockets. They're questioning things. They're pushing things off. Also, there's probably some argument that because providers know that there's becoming greater challenges, we've probably seen even a slower growth in the pricing side of things. So a lot of things are changing in that arena as we move forward. So as it says, right here, these factors are going to require providers to move towards a different model. In today's model, or at least in the past, the goal would be to get a patient in the door and figure out how many different services you could provide to that individual patient. Everything was driven on volumes. The more volumes I provide, the more money I make, the better opportunity I have to produce a bottom line. Whereas when we look at what's happening because of the change in payment methodologies, now we're going to be moving towards something that is focusing on the value of the service. What am I getting for the dollars that I am paying, and how does that compare one facility to the next? So, definitely something that we have to be watching. Value is being changed to a definition now of quality divided by cost. So that's going to be an important piece as we move forward. So the road to value will be a bumpy one as payers change their payment models. And what this means is that the hard part for providers is going to be that the payment model isn't going to change for every payer on the same day. Some payers are going to continue to pay on volume, while others are going to be paying on value. And those that are paying on value may have different definitions of how they determine that value, and that is going to create a lot of different challenges in the marketplace for the provider. So with all of that uncertainty, as things change at varying levels, it's going to even be more important that providers start figuring out, how do I strengthen my bottom line today? That's the preparation we need to be looking at. How do we strengthen our financial position today so that as the payment streams start to become a challenge, how can we be prepared for that? How can we make that happen? How will we be successful? So the real first strategy for transition is to improve our financial indicators. What this will do will improve our ability to sustain financial performance in the future. The more lean we become, the better cash reserves we have, all of those components, the more we have, the better off we're going to be as we move forward into this time of uncertainty. Because reserves are going to be extremely important, and that's going to be a challenge for a lot of our smaller providers. So we have these 10 indicators, and so 10 indicators really need to be monitored and managed. And what we want to do now is make them as strong as we possibly can. So the 10 indicators that we recommend to review and to monitor came out of a Critical Access Hospital Summit, a financial leadership summit in 2012, which I was fortunate to be a party of. There were 15 of us participants, and we came up with those top 10 indicators. Those indicators that we feel are the best of all of the indicators out there to give you an idea of how a provider is doing financially and operationally as an organization. There are definitely a lot more indicators than this available, but we've determined that these are the ones that are traditionally the most valuable. the ones that are going to give the greatest value to an organization as you are looking at the options. The others can definitely be used. Typically, I would start looking at those if you identify a problem in a certain area. It might help you diagnose what's going on in greater detail within that area. So these indicators, these are the 10 days in net AR, days in gross AR, the amount of days cash on hand that the organization has, total margin, operating margin, the debt service coverage ratio, salaries to net patient revenue, the payer mix percentage, average age of plant, and finally, the long-term debt to capitalization. And we'll walk through each one of these individual indicators to provide some understanding. You'll notice there's two of them in the area of accounts receivable. The first one is the days in net accounts receivable. And what this measures is it looks at how many days does it take the organization to collect your payments. And since it's done on net, it takes net patient accounts receivable, net meaning what were the gross charges less any contractual allowances or adjustments that are expected due to contracts with payers, Medicare write-offs that we have to put in there, divided by the net patient revenue, and then dividing that by 365. Now, what you want to be as an organization is you want to be below the median on this, meaning that it's taking you less time to collect your money. You're more efficient, you've got better processes or whatever in that area. And so when we look at this here, if we have an organization that's struggling, is above those numbers, typically the types of things that would cause them to have an unfavorable calculation would be inadequate registration or collection processes. And at registration, what we oftentimes find is that we have organizations where they're not getting the demographics right. They get the wrong address. They get the wrong insurance number, which is very common today with a lot of people changing insurance companies as their own firms or their employers change, or they go to the marketplace. Those things being missed. The other thing is that with the higher deductibles and copays, organizations have to be much more proactive in trying to come up with a payment plan on the front end to try to collect these dollars and cents that they have coming to them. Poor communication, this could be communication internally with insurance companies, etc. And then finally, one of the big areas is just charge master problems. You know, we hear a lot about people looking at their charge masters, but the charge master is an extremely complex component, and even in larger organizations, they struggle with keeping that current. And if you start having a charge master that's out of date, now you start reporting some codes and things that Medicare doesn't recognize, other payers don't recognize, and this kind of drives up those days in accounts receivable. Days in gross accounts receivable is a very comparable calculation, except it uses gross revenues, you know, that initial gross charge without looking at the deductions or contractual allowances, dividing that by gross patient revenue divided by 365. Again, this is a favorable value would be below. And here you can see the median is the same as the net. Over time, these two numbers should equal each other. The difference will be just due to the estimates that providers are using for their contractual allowances in the net calculation. The causes for unfavorable values, once again, are going to follow the same things that we would see in the area of net. Days cash on hand. What this measures is the number of days that an organization could operate if they were not able to collect any additional cash. So if a cash coming in stopped today, how many days would I be able to operate before cash was gone? So that looks at cash plus investments and divides that by the net operating expenses less non-cash expenses such as depreciation and bad debt, assuming bad debt is included in their operating expense, dividing that by 365. And here, the organization wants to be above the median, meaning that you could sustain a longer period of cash flow disruption, which is one of the big concerns as we have payers changing to different models, which could affect profitability as well as billing methodologies, et cetera. So national U.S. median for 2012, 69.07. When we look at what could be driving this down from one provider to the next, one would be poor profitability. If you don't have profits, it's hard to collect cash, or at least it's an appropriate amount of cash to keep the doors open for a longer period of time. The other thing is that if we look at the first two calculations we looked at with days in receivable, if those numbers are high, if we have an excessive amount of our assets sitting in accounts receivable versus cash, that's going to drive down our days cash on hand. So we're going to have two areas in the area of margin. One is total margin. This looks at the ability of an organization to control their expenses in relation to the revenues that they're able to generate. And this is reported as a percentage. So it's the excess of revenues over expenses divided by total revenues and then times 100. So the median of 2.61 in 2012, the favorable position would be to be above that, to be more profitable than what we're seeing out there in the median. And the important part is we look at trying to build up all of these numbers and prepare ourselves for the future. We don't want to be just at the median. We're going to want to be a fair amount above the median, or better than the median, to help bridge that gap that'll occur as payment models are changing. If you have an unfavorable value here, first of all, high expenses, high expenses in relation to the amount of revenues that you are receiving. It could also mean that you have some problems in your revenue stream. You're not charging for all the things you should, or the right pricing for all those things. So it can also be on the revenue side along with the expense side. The other thing is it could show that there's a lack of public financial support. And what we mean by that is that many of our rural providers will get some sort of public funding, a tax base, something through a hospital district, things like that will push up the total margin for many organizations. So as you look from one facility to the next, if you're below and you don't get any public support, that could be part of the cause for it. Then you got to figure out how are you going to make up for that challenge or that additional component in your organization. Then we have the operating margin. Now the operating margin really looks at how are you controlling this expense, operating expense, relative to the operating revenue. So this doesn't look at all those excess dollars that you might be getting from taxes in the hospital districts. This is looking at what is the operation generating. So it's net operating income divided by total operating income times 100. Favorable values are going to be above the median. So you can see the national median here is 1.13%. Here you have an unfavorable value. You're looking at high expenses in comparison to your revenues. Again, could be a revenue problem. Also, if you're not capturing the charges and billing at the right dollar amounts, et cetera, for the services that you are rendering in the organization. We then move into the area of debt service coverage ratios. Debt service coverage ratios looks at, how many times would you be able to pay your debt? And the numbers there, and I see that this slide is in error, so I will have to add the definition here and get that forwarded to Kim to forward to you guys after the presentation. But what you're looking at here is how many times can I pay my debt in a given year? And so that can become another factor that an organization wants to be strong on. Salaries to net patient revenue. The definition here is, it measures your labor costs relative to the generation of operating revenue. What we know out there is that the higher this number is, the lower the profitability tends to be in an organization. So how well can they manage their labor costs? It's salaries divided by net patient revenue. U.S. median for 2012 was 44.87%. And when we look at this here, if your number is high, most often it's going to be an issue of poor productivity, meaning that it's taking you more staff time to get the same work done as another organization of equal revenue. One could argue it could also be an indicator that your salaries per FTE are higher than other organizations. That doesn't tend to be as big of an issue, but it could be. Typically, it's going to be some sort of a factor of productivity that is causing that problem. Payer mix percentage. What we're looking at here is what percentage of our volume is coming from Medicare versus other payers. And this one here is a really important statistic that is oftentimes misunderstood, oftentimes probably ignored. What this looks at is you can do inpatient and you can do outpatient. Inpatient is the number that is typically easiest to identify. So inpatient is the inpatient days for the payer divided by the total inpatient days minus nursery days, any non-skilled swing bed days, to come up with a percentage. Now the favorable value here is below the median. And the U.S. median for Medicare inpatient for critical access hospitals was 73.59%. And the piece that sometimes gets misunderstood is there are some organizations that think the higher that number is, the more Medicare volume I have as a percentage, the better I am going to be off financially. The lower that number is, the worse off I'll be, because we get paid costs for those services, and cost can be a substantial number. The problem is that to generate profits, you actually have to have payers that will generate a profit. Cost plus 1% is not a profit, especially when we know that Medicare doesn't allow all costs in the calculation, plus we have sequestration sitting out there. So the goal here is what can we do in the organization to drive up the Medicare, the non-Medicare volume to surpass the Medicare and decrease our total Medicare inpatient percentage. So when we see a facility that's struggling here, it's a failure to market to or to capture the non-Medicare patients. So what are we doing there to try to capture them, bring them into the fold, and increase our bottom line over time? Average age of plant. What this looks at is basically by calculations through depreciation is what is the average age of my organization, being my building and my equipment. And here, the goal is to be below the median, meaning that I have a newer, hopefully more modern organization, because while this does typically increase the amount of expense we have, having a newer building, a better technology, et cetera, tends to also attract more patients over time and is a positive in the organization. So the favorable value there would be to be below the median, and the U.S. median in 2012 was 9.83. A lot of reasons why this could be in excess of 9.83. One could be poor profitability, so you don't have the ability to replenish property and plant. One could be just a conscious decision that you weren't going to replenish and you were trying to stock up on cash reserves, etc., it's a delicate balancing act within the organization to make sure that you have the adequate plant as well as balancing all the other things. Long-term debt to capitalization, what this looks at is of the amount of assets that we have, how much of it is being funded through debt? And so what this looks at is long-term capital liabilities, typically bonds, notes, etc., divided by net assets. And the favorable area to be would be to be below that number. U.S. median in 2012 was 17.26. And so an organization that has less debt will have a greater long-term debt to capitalization. The better that number is, the better the ability is to go out and get future debt if you need it in the future, as well as just the fact that you don't have debt that you're having to pay off can also help you in your debt service coverage ratio calculations. So why now? Why in the future? This gets into that, how we start planning with this. So these indicators, as we look at them, tell us how we're doing in some very specific areas. First of all, it tells us about our profitability. So when we think about our profitability, it tells us in the total margin and the operating margin, it tells us how are we doing in comparison to the median. And again, the nice split between total and operating, the operating meaning, again, how much am I doing through the operations of the organization, total margin, you know, how does that improve when I start looking at public support, investment income, things like that. Next, it tells us how we're doing as far as liquidity. And that is, you know, how much cash are we, and how well are we using that asset. So days cash on hand, and where are we at in our accounts receivable. And we want high days cash on hand. We want low days in gross and net AR. Tells us how we're doing in our capital structure. You know, if we have a high debt service coverage ratio, that's good. It means we can pay our debt several times over in a year. We have a low long-term debt capitalization. Again, helps both of those calculations. Revenues, the payer mix percentage. And then the last being the cost, knowing, you know, what are our salaries to net patient revenue, what's our average age of plan. So the importance today is it tells us how well we are able to manage things today. Why is it in the, by the way, today if we can have these strong indicators, it'll help us get the resources we're going to need in the future. You know, I know a lot of people are saying, well, I'm going to wait. I'm not going to make any changes today. And it's like, no, we need to make those changes today so that we can build up our cash reserves. Cash reserves are going to be so very important in this transition because of that varying time period when people are going to change their payment model, the inconsistent incentives, some people paying for volume, some paying for value. You're not going to be able to monitor that patient by patient. It's going to be a challenge. And then with these transitions, we'll have new billing rules. And every time there's new billing rules, we know that things happen to cash flow. So we're going to want to have as much liquidity in our organization and profitability prior to all of this occurring to prepare us for those changes. Tomorrow, when we think about this, financial challenges are only going to increase. You know, when I'm out visiting with providers, when I'm out visiting with payers, when I'm talking to government officials, there is no one out there that thinks that there's going to be a huge infusion of additional cash into the healthcare system. If anything, reimbursements at best may maintain where they're at, and most likely will start to have pressures to retract them. And we are seeing some providers that are pushing out contracts with lower reimbursement than what they have provided in the future. Okay? So we really want to make sure that people are doing something today, because if you don't, the ability to survive in the long term is a real challenge. The other reason why we want to be looking at this here, on an ongoing basis today and into the future is that the more you monitor these factors, even if they're doing well, they at least start to show you where there's trends. And if things start to go poorly, you can start doing early detection, you can do earlier intervention, and you can hopefully prevent some significant downturns in the organization as things transition. The goal is to perform at a level much better than the national, regional, and state averages and medians within your each indicator. Okay? And the reason we say that is I have a lot of facilities that say, oh, yeah, but we're at the average or we're at the median, so we're doing just fine. Well, the average and median organization, CAH, in this country today is struggling. And that's not where we need to be benchmarking ourselves to. We want to be benchmarking ourselves to be stronger than that, because that's the only thing that's going to give us the ability to sustain and to move forward into the future. So how do we monitor these? I think you have to monitor all 10. I have some people sometimes ask, well, I don't want to monitor all 10. Which ones are more important? Well, the one that's probably the important one is the one that you're not doing well on, and that's going to vary from one organization to the next. So monitor all 10 of them. Even if you're doing well on them, do monitor all 10 of them. And so what we want to look at here is, monitor monthly, quarterly, annually. I have people that look at all of those. I like monthly. Okay? Quarterly and annually, that's kind of maybe nice, but if you wait annually, you've lost an opportunity that could be 11 or 12 months old. If you do it monthly, you've only lost a month. And you can start making changes, especially if things are trending in the wrong direction. I think as we have systems improve and become more sophisticated in our rural setting, that we will get to a point where we're looking at these things on a weekly basis, and at some point maybe even daily. Where are we at? What's happening, so that we can make changes on the fly throughout the month as things are changing. And then comparison, I would look at both state and national. The Flex Monitoring Trend Reports give you great state information as well as national information. I think sometimes, it's nice to look at state, but if a state is struggling as a whole, you really want to see what's the rest of the nation doing too, because they can do it elsewhere. Why can't we get there if they're doing better, performing better as a state or as a nation versus the state? So definitely look at state and national, monitor all 10 of them. There's a lot of information that can be derived from those. So when you monitor these, don't look at just am I above or below. The value itself, the number, is important, but I really like to see the trend. I think too often when we get called into an organization, it's because the number has just become inappropriate for the organization. Their margin has either dropped or their salaries have went high, and they're at a point of potentially hemorrhaging financially, and it's really hard to make changes quickly in an organization, whereas if they would have been watching trending, they may have seen that their salary numbers were moving up over time. They could have seen that their profitability was starting to fall, and that's the best time to implement and engage in changes in the organization. It's a lot easier to do it at that point versus waiting until we have a problem. And then as we monitor these, you have to do more than just monitor. If there's a problem with a number or a trend, something that we see that is concerning, the next piece is that now we have to initiate an action. What are we going to do to change that number? Too often what we hear is, and there's a number that's not doing what it should, and we'll say, well, what are you doing now? And they'll say, well, we're going to do the same thing we did in the past and see what happens. Well, we know what happens because we have the calculations from the past. we need to start initiating a change. What do we need to do to bring those salaries down as a percentage? What do we need to do to decrease our days in AR? What do we need to do to increase our operating margin? What is the action that's going to happen? If we're just reporting the values, nothing is going to change to the positive, most likely, over time. So what is happening to the organization? What changes need to be made? And then finally, who's accountable? What accountability has been assigned to whom in the organization to chase that number to improve it, be it accounts receivable, be it salaries, be it margin, be it age of plant, be it whatever one of those, debt service coverage. Who is responsible and accountable to make that change in the organization to help improve the overall strength of the organization? So strong indicators are definitely going to put an organization in a lead position. Again, building those reserves. Those financial reserves, and I know I have said that several times in this presentation already, but that is really key. How are we going to put as much cash and cash equivalents back for those challenges that we all know are going to be there? And as we look at this, with a lot of these transitions from volume to value, we're going to have to reach out and have new relations with other providers because we're not going to be everything to everybody. Now, that doesn't mean that you have to be purchased or bought out, because everybody always thinks, well, no, we're not going to let anybody buy us out. That's not what I'm talking about. It could be that, could be an acquisition, but it could be an alliance, it could be an affiliation, it could be any type of relationship to help enter into some of these markets. Let's say if you end up having to be part of an accountable care organization or a bundled payment program or something in the future. Weak financial indicators may be something that creates a greater difficulty in finding a partner. Because people who are going to be partnering with others are going to be looking for individuals that have a strong record, strong value, quality, and financial performance, because they don't want to get in with somebody who isn't going to be there in the future or that somehow otherwise could drag them down. Okay? And again, these indicators, the other importance of having good, strong stuff now is that past performance is a great indicator of future performance. So as you're out there courting, some people say, well, yeah, if we come together, then we'll be able to improve our bottom line. Partners want to see that you already have a bottom line, something that you've got some demonstrated past with. So definitely some things that people will be looking at that. It's really hard to sell that things will get better when we come together. And the other thing that's really important is, even if you are looking at the acquisitions, the affiliations that have cash, infusions, is that potential partners, some of the larger organizations that in the past may have had an appetite for helping fund some of the smaller organizations, critical access hospitals, is that they now have found it to be a challenge to have the cash reserves, and they're having to secure and maintain their own cash reserves, and are less likely to help push funding out to that smaller organization, the critical access hospital, to be a partner. And then we have to, look at, all of this will help us in time document value. And what we mean by this is that as we bring some of these numbers down, especially when we start looking at some of those cost indicators, since part of the calculation of value in the future is cost, as we drive down our cost, that's going to help us to demonstrate part of the value calculation. And that'll give this, give a lot of additional good information to our patients, to payers, to some of our strategic partners, which could be the affiliations. It could even be the physicians that are referring services to us. The better we can manage all of those indicators, it gives us a good start on documenting value. Now, we're going to have the quality side in there. Absolutely going to have to be working on that, and that's another whole conversation. But we need to work on the cost side. How do we drill that down? How do we bring that into the right level as far as the organization? So when we look at some of these factors out there, some of the different models out there, some of the reimbursement models out there, we really want to make sure that we're doing this early on before Medicare identifies a program, let's say such as value-based purchasing, which we know is not there yet, and we'll talk a little bit more about that in a few minutes. But when Medicare announces that, or some payer announces that they're going to apply a new payment mechanism, the problem or the challenge is that they use data that we've already created in the past to pay us in the future. So we need to make sure that we're creating good data now before they announce it so that they have good data, good value being demonstrated when they initiate the program. Because once they initiate the program, if we have bad data that's hindering the definition of value, it takes a long time to change those numbers, to decrease the cost, to improve the quality. All of those things takes a long time period, and it could be too long for us to even make the transition. So let's talk about value-based types of services. I'm going to talk a little bit about what's going on in the area of PPS, the acute care hospitals. And you may be asking, well, why would we start there? It's because what we see in the PPS model typically is what we will eventually see within the critical access model. So if we look at the value-based purchasing under the PPS model, what they look at there is it adjusts payments to hospitals, DRG payments, based on the quality of care that they furnish. And so they have 4 factors now that they are beginning to look at. One is the clinical process of care. And in that arena, think of, the timing of tests, the timing of interventions, orders, test results. Then they get into patient experience of care. That's the one we hear an awful lot about nowadays with the HCAHPS, those patient satisfaction surveys. Then they'll be looking at outcomes. What are our mortality measures with acute MI, heart failure, pneumonia, and central line associated bloodstream infections. And then finally, efficiency. And what they define efficiency is the Medicare spending per beneficiary. Think of that as being the cost. And to date, the way that they handle value purchasing by Medicare in the PPS realm is it is a winners and losers type of calculation. What they do is they hold back a little bit of money from everybody. So they take money from everybody in the payment model, and at the end of the year, they distribute that out to those that have demonstrated the value. So everybody will put money in the pot, fewer will take it back out. And so some will become winners, some will become losers. So here is the model that's being used in the PPS world today. Started in 2013. You can see how it's transitioning for the first 4 years. Started out heavy on the clinical process of care and then the patient experience factor. As we go forward, you'll notice that the patient experience factor maintains its level of importance in the total weighting. The clinical process of care starts to drop down. So while those are important, that we have all the interventions and everything done right on the front end, what they start doing in 2014 is adding in, what are the outcomes? Not just, gee, what did you do, but how did it affect the patient? So you can see that number growing from 14 through 16. And then In 2015, they started bringing in that efficiency. What's your cost? And you can see how that's starting to increase a little bit in the amount of weighting in the organization for those payments. And then the way that they affected this through the PPS model, excuse me, is they began with reductions of 1%, which means they would take 1% of the of the payment away from everybody, and then they could give back money back to everybody of 1% or some to 1%. So that money goes back at the end of the day. And then that goes all the way up to 2%. I had to change a headset here as my phone was dying, so I hope I'm still here. Anticipated payment model for this will also be going to critical access hospitals. And what we anticipate we would see at some point in the future would be that the adjustment would be to the 101% of payment. So right now a hospital gets 101% of cost in their reimbursement as a critical access hospital. We would anticipate at some point in time that maybe they'll take 1% to 2% off of that from everybody, and then at some point in time would pay that to a small group back. So there could be some winners and could be some losers. The important piece is that when they would begin this, if they would announce it, let's say tomorrow, they would be using data that's been created in the past, which is, again, why it's important to make sure that we have good data today in preparation for that transition. So here, the ability to manage these quality indicators is going to help us if we reduce our costs. If we have to make tweaks, it'll reduce the learning curve because we'll already have done a lot of the work. If we have to improve our quality, we'll have at least done some things. We'll be able to reduce that curve. And as we look at the value-based, really what it's going to do to us over time is it's going to help demonstrate value. You know, it's going to demonstrate value to the patients, the payers, potential partners. The better that we can demonstrate all this value, the better positioned we are going to be as we go to move forward. So, key strategies overview. What we need to be looking at here is identifying and monitoring those 10 financial indicators. Those are extremely important. I have some organizations that are monitoring all 10. I have some that monitor only a couple. Some do it on a fairly regular basis. I have some organizations that the only time that they ever see those numbers is when they get their financial audit. You know, we need to be watching those things. We need to be changing things in our organizations to improve the strength of those components as we move forward. Successful providers will be able to improve their ability to remain financially viable and stable during the transition. The transition is going to be an extreme challenge to organizations. And unfortunately, we'll probably have some organizations that won't make that transition. And what we need to be doing is working with, as an organization or with organizations, to help improve the strength of those numbers, because as we start talking about other strategies of how to, you know, enhance things going forward in the next two sessions, the more successful we can be in monitoring these numbers, the better prepared we will be for that future. So with that, I will turn it over to questions.
Thank you, Ralph. It looks like Jill Bullock has a question. Under the slide, value, PPS, value-based purchasing, will the VBP model be based on MBQIP quality domains?
For CAW, we wouldn't know. I mean, that's the piece we don't know. That would be a great place for it to come from. But, you know, as these things develop, those would be, you know, part of why it'd be really important to make sure people are you know, keeping up with all of those quality domains. You know, we don't know where those are at. So that's why I always tell providers, you know, when it comes to like CPT coding and documentation and ICD-9, now going to ICD-10 coding, and they say, well, it doesn't matter because I'm a critical access hospital. it may not impact your CAH reimbursement today, but it's telling somebody the story of your patient. And we need to make sure that we're doing that to the greatest of our ability all the time.
Okay, does anyone else have any questions for Ralph today? You can either type them in the chat box or press *2 to unmute your line. Ralph, why not monitor all of the indicators from the Flex monitoring report?
You know, that's a good question, and we get that often. I do have a number of people that will say, gee, there's 20-some different numbers out there. Why don't I monitor all of them? And you definitely could, but it takes time. It takes effort to monitor all those components, and that's kind of part of why when we came together and we came up with the 10, it was which 10 tells us the most and really gives us an indicator that there's some sort of a problem out there. And then we can start digging deeper by using some of the other statistics, and indicators. But trying to do all of them all the time, that gets to be a lot of overload. And when we think about all the things that get added onto the organization, from a reporting perspective and, not just financially, but, quality and all those other things, what we were looking to do is come up with what were the most important pieces that would give them the greatest bang for the buck, and that's why we came up with 10.
Great. It looks like we have about 10 minutes for questions. This is a great opportunity. Does anyone have any questions for Ralph? Ralph, can you explain why the patient experience is considered an indicator in value when it doesn't necessarily mean I'm providing good care?
That is a great question. When we think about that one there, and there's a lot of people that challenge that one, it is very true that when you go through all the indicators in the HCAHPS, in the patient experience, that a lot of those things may or may not be indicators of quality of care. If my halls are noisy, how does that mean that I'm not doing good quality or good value? And the reality is that, that's the document that they use. Now, as we look at some of those things about, is my pain being managed? Am I being told about, my meds and things like that? If we're doing those things on a regular basis, it's most likely going to affect the quality of care. But that is an area, when you think about the patient experience, of why we're starting to see a lot of organizations focus on customer service training. And, thinking of, trying to act and feel and look like, a high-class hotel. When you come in and you're greeted with that smile and, you're treated like royalty from beginning to end. And so we're seeing a lot of organizations do all of those things because they do affect the HCAHPS score, which over time will affect the value-based purchasing component. It's important to note when you think about those HCAHPS and the customer service training that you may do, it's not just focusing on clinical. I mean, it's important to focus on the clinical side of things on the HCAHPS, but a lot of those questions have to do with things that have nothing to do with the clinical component of care, which is where the questions come into of how does that determine value. The people that would be involved in this type of